moment and take a look to make sure their microphone's muted, because there's certainly some scatter on the over the mic. So not to say that we would want you to jump in and interact. I saw some really great names on the list and some familiar faces. Although I cannot see your faces right now, I did see some friends, and I want to say, as practitioners who are working in this regenerative sports medicine space, or just sports medicine, or just trying to learn, I've learned so much from so many of you who have joined on this call, and I'm grateful for that. You know, being a physician, we have to teach as best as we can and share this knowledge so that our patients can get the best outcomes. And I found that MD Biologics is very interested in helping us along that way. Today's discussion, although about Synalus VA, which is a viscosupplement, I would say that we're not just talking about Synalus, we're talking about viscosupplementation on a whole, and I really am happy that we will have the discussion about essentially what are the factors when we consider different viscos. For those of you who don't know me, I'm a medical doctor who's been working throughout Canada for the last over 10 years now. My focus is, as Connor stated, primarily, actually it's almost exclusively in regenerative sports medicine. Anything that helps people heal, rejuvenate, and preserve their joints, that's where my focus is. And I got started up with that at Cleveland Clinic Canada, which was a fantastic place to work. And for the last few years, I've been helping out with Frank Johnson's course, which is a sports medicine ultrasound course. If you've never taken it, I highly encourage you to do that. And I've been the medical director and founder of Regenerative MD, which is based in Calgary. And it's been fantastic. And most recently, I came across this product, Synalus, I shouldn't say most recently, over a few years ago, I came across Synalus. And I found my patients just to be wanting to switch over quite a bit, especially the active populations who have mild to moderate OA. So with noticing these trends, I thought, this would be a really great product to dig into. And I was really happy when MD Biologics picked it up and has been doing probably the best job I've seen with reintroducing it into Canada and encouraging people to understand the different properties that make it distinct. Not to say that I don't use other viscos in my practice, simply that this is probably the main workhorse for me. And we are, we're doing quite a few treatments on a day that we treat. And I'd say probably about 50 to 60% of my visco cases end up being with Synalus. It might be because I have a very active population, but certainly because it's been effective and patients are asking for it. The unique properties about this are that it's been designed in a way that where it mimics the properties of normal synovial fluid. That's what we're going to touch on during this lecture. It is a high molecular weight HA. It's combined with sorbitol, which does its very natural cross-linking and helps it form into this gel-like substance that you see on the right of the screen, which has a nice sort of turgor to it. There's a flexible treatment protocol with this, 4 mils and 2 mils. So in situations now where we've lost some viscos where you could do that single injection for the smaller joints, or if you want flexibility with doing 2 mils a few times into a joint, that can be helpful, or just go with the larger volume of 4. In Canada, although I use it for essentially all large joints and even small joints, the indication is for knee osteoarthritis, but certainly I put it in hips, shoulders, everything. So based off of my own clinical experience, it's been excellent for the treatment of early knee OA. It's my preferred treatment for GH joint OA, especially in those active populations, people who want to get ahead of arthritis. Even patients who are concerned about animal products, because it is a non-animal based hyaluronic acid, and those wanting a faster onset. The VA in Synalus stands for viscoanesthetic. For anyone who does prolotherapy in our audience, you'll know that they would tell you that the sugars are, there's something about them which has a viscoanesthetic property, and sorbitol certainly falls into that category. Patients who are wanting a more natural solution with a reduced likelihood of reaction, certainly if they've had a reaction before, that's when I consider using it. I combine a lot of HA with PRP And almost exclusively, I use Synalus when I'm combining it with PRP because of its non-animal base. It doesn't have any chemical cross-linkage. And further to that, it's low reaction rate and high safety profile. And the last thing I'll say is on this slide is its ergonomic design. When you do as many treatments as many of us do, your hands can cramp at the end of the day. And I really like the feel and the smoothness of this injection. So certainly a very light consideration, but a consideration nonetheless. So our focus initially will be on Synalus, but we're going to get into an academic portion to this lecture as well. But I just want to state some of the obvious terms about Synalus VA if you are not familiar with it. I've highlighted them already, but really they're here non-animal origin. It is a 2% HA combined with sorbitol 4%. Sorbitol has an antioxidant property to it, but it naturally cross-links the HA. It's a high molecular weight HA. As I mentioned, no chemical cross-linkage. And we're going to talk about this idea of crossover frequency, and certainly we'll touch on some of the published clinical data. There is an immense amount, which is largely completed in Europe and in France. This is a product from Switzerland. Sometimes when you tell patients, "Oh, I can give you the Swiss HA," especially people who are into some of the aesthetics, Switzerland has a very strong manufacturing base when it comes to pharmaceuticals. So sometimes it can become a selection of their choice. All right. If anyone really wants to chime in about something, please do when you need. It's really hard on webinars to read the room. One person ends up talking the whole time, and it's certainly not as interactive as some of the discussions we've done. But I will continue on with something that I have found very interesting, which is the research of HA and where sort of the basics of it came from. And so here's the medical discussion, which is not Synalus specific. It is really for all of our education. A lot of the scientific discussion that we have is based off of this textbook written by a few Harvard pulmonologists and critical care intensivists that wrote a textbook called The Chemistry and Biology of the Hyaluronic Acid. And in this textbook, when you go through it, and I encourage you all, take a screenshot of this if you want, they really are talking about how HA and how product essentially flows, and that's fluid dynamics. So there's certainly an engineering principle behind how all of these HAs and the fluids in our joints are meant to interact. And when you go through this textbook, you will learn so much. So I highly encourage that you do it. I don't think we get enough basic science when we're choosing HAs, but that's where a lot of this information is going to come from for you for this lecture, as it's related to Synalus and other products. Now, the thing to know about HA is we think that, it's just HA in the joint, but of course, synovial fluid has multiple constituents. There are components to it. Hyaluronic acid being the main component of synovial fluid. The thing I want to point out, hyaluronic acid isn't all the same. So first of all, it's production methods and whatnot, but I want you to think of it as these long chains of disaccharides, which can, be 10,000 or more, and that long chain is what turns or what accounts for the molecular weight of the chain or of the hyaluronic acid. The thing is, we've always been taught that high molecular weight is good or it's better. And it's not that it's bad. You certainly have to hit a certain molecular weight to be good, but the more that you have inside of a joint, the more restrictive it can be at times. Sorry, did somebody want to chime in there? Okay, I'm going to keep going. So a longer chain has a higher molecular weight, but certainly that higher molecular weight can at times be restrictive because it doesn't move as well. And when we get down to the importance of synovial fluid within the synovial joint, there are two cardinal principles of what the HA inside of synovial fluid is doing. And those cardinal principles are that it protects cartilage by absorbing mechanical energy via its rigidity and its elasticity. And I want you to remember those two terms, the rigidity and elasticity, because that essentially is what we call, it makes up the viscoelastic properties of synovial fluid. We need it to essentially give it a little bit of bounce at times. The second principle of HA in synovial fluid, like what does it do, is it has an elastic protection mechanism for the mechanico-sensitive apparatus of pain receptors. So think of it as compression of a joint, and you need to have elastic protection for the nociceptors so that they don't essentially get triggered. So knowing that we have HA showing up in certain ways that it supports the joints, naturally medicine decided that viscosupplementation, something that you all maybe do, was the way to approach this problem. Add more HA into the joint and you'll be able to help those two cardinal principles. And when you add HA, what you're really doing is you are improving the fluid dynamics within the joint. You're trying to protect the cartilage by increasing viscosity and elasticity. As we increase the concentration of HA, what should happen is the viscosity and elasticity improves in a healthy joint. Now, if you take a look at this graph here, in the bottom right corner, I want to point out this gray area, and that gray area is of an osteoarthritic patient. And the point that this graph makes is that an osteoarthritic patient doesn't adapt their synovial fluid and HA as well as a healthy patient. When you add HA into a joint, the viscosity and elasticity improve, especially in a healthy case, but it is certainly more difficult for an osteoarthritic case. So, synovial fluid, it's viscoelastic. It adapts its state and speed, it adapts its state to the speed of movement and the constraint. Viscoelasticity, it's affected by concentration and molecular weight. So as the molecular weight increases and the concentration increases, you can kind of get a more dense substance on the inside of that synovial joint. And then crossover frequency, it's a characteristic of that same viscoelasticity. And crossover frequency is not something that is commonly taught, nor is it something that I heard a lot about until I dug into this textbook. And this textbook that I had shown you earlier was the place where you could really see that there are different properties to the HAs. But the most unique property of the HA that I don't think many of us are aware of is that when we are sitting, or when a patient is sitting, HA sits in a more viscous state. It is essentially limiting the friction by sitting in that viscous state. However, when a person starts to move, there is mechanical stress on that joint, and the HA becomes a little bit more elastic, and it provides shock absorption. So that's the whole idea of viscoelasticity. So remember, it is not steady state. There's a fluid dynamic property to the HA, to all HAs, in fact, to an extent. But healthy synovial fluid certainly has this viscoelastic adaptability inside of it. And if you want to read more about that, certainly the chemistry and biology of the hyaluronan will teach you tremendous amounts of it. Chapter 20 will be the one that you want to focus on. So if we know the basics of HA, all HA gel products, well, are they the same? We know that they have to have this viscoelastic component to them, that they have to have a certain molecular weight, but we have all these products on the market, Synalus just being one of many. And how do you choose? I mean, in all honesty, when I was first taught this, 15 years ago, the idea was, just choose one and then try that one, and then you move to the next one and whatnot. And it didn't seem like we were doing it justice. And certainly that was a lot of my inquisition. So are they all the same? What is it that you might consider when choosing a different HA, one versus another? How do they actually compare? Like, do we as practitioners know the individual properties of each one? Should you? Do you think it matters to your practice? And are there better products for different situations? And I would say that In the case of all HAs, certainly there are better products for different situations. Certainly that comes with a little bit of clinical experience, but myself, I think MD Biologics as well, we want to add a little bit of credence to this discussion in terms of the intelligence that we have when choosing, because certainly it's not something that we are thinking about at all times, or classically have been thinking about. I don't know how many of you have seen this chart, but I think it's a very important chart to know. I have this in my office and I use it very frequently. So the initial focus was always on the molecular weight of a product. The implication was that you needed to have high molecular weight, and somehow we almost deduced that if you have a high molecular weight, the higher it is, the better. But that's not necessarily true, because there was very little discussion on concentration. Molecular weight and concentration sort of work together within a closed system of the joint. Safety profile sort of gained a little bit. Sorry, what's that?
Thakur.
Yes. Oh, can you mute? Can you please mute?
First name Gore, last name family name.
Okay, well, I'm going to continue on.
Sorry, I'm not able to find who in the meeting is unmuted. Oh, my apologies. Actually, I might have. Okay, continue. Sorry.
Okay, thank you. So what I was trying to say is that molecular weight and concentration interact together, but high molecular weight, high concentration can have a trade-off, and that it creates a very restrictive system inside of a joint. Safety profile then gains a little bit more attention. And I think that's happened, I think we've become all very aware of that with the pseudosepsis reactions that have occurred classically. Certain HAs had more reactions, and that was frequently blamed on animal origin and also cross-linkage. Particularly chemically cross-linked product seemed to have a degree of reaction associated with it, and then animal origin product can as well. It's not to say that it shouldn't be used in our practices, it's just something that it affects the safety profile and sort of the complication profile with patients. Viscoelasticity, as I mentioned, it's affected by the concentration and molecular weight. So essentially that ability for it to bounce and evolve itself within the joint depending on its need. Concentration is an important factor because the greater that concentration, you are essentially increasing the density within that closed system, which is the joint. And something that I don't think many of us have a strong working knowledge of, certainly nothing that came up in my training until we begin to dig deeper, is the idea of crossover frequency. And crossover frequency, as I stated, is the ability for that HA or the synovial fluid, to adapt itself. And crossover frequency is something that we should know about depending on the activity level of our populations. So, HA concentration, well, you essentially have to hit 10 milligrams per milliliter in order for enough entanglements to occur for there to be a molecular interaction that gives it a certain rigidity. Without that, it doesn't really form a gel. When you're below the 10 milligram per milliliter mark, you frequently have to use chemical cross-linkage to keep the HAs together in a gel format. So concentration is a factor that, again, interacts with the molecular weight of the product. So at concentrations around 10 milligrams per milliliter, there exists enough interactions for the hyaluronic acid to form these natural gel-like entanglements. If you don't have it, sometimes you need to cross-link. So sometimes you get products that have a lower concentration, which therefore need chemical cross-linkage. Others chemically cross-link just because they want to form even tighter bonds for their gel. Debatable as to whether it's good or not. It may help with its lasting impact within a joint. So those are those 2 points that I just wanted to make there. Now, when it comes to Synalis, they really focused on this intelligent design component, which was it increases the safety. They increase the safety profile by creating a non-animal origin HA with no chemical cross-linking. For a reminder, listen, there's 2 ways that HA is sourced. There's animal origin HA, there's biofermentative origin HA. Biofermentative is certainly the more novel way of doing things. It does have less impurities with it. It is not animal based. It's from the proteoglycan layer of bacteria, specifically of Streptococcus equini. Now, you can't get as high of a molecular weight via biofermentative origin as you can with rooster comb. However, you don't need to have the highest molecular weight to have a significant impact. So the more recent technology is biofermentative origin, a lot more control. And that's how Synolus was designed. That was its production method. So no chemical cross-linking. In fact, sorbitol, which is the sugar alcohol that's added to it, is the piece that helps it stabilize itself. So just back to that same table, there are chemically cross-linked HAs. Again, it may add stability to the product to help keep that product in the joint. In the case of Synolus, which is the bottom one on that row, chemical cross-linkage was not used. An interesting approach for a high molecular weight, high concentration HA. Why not cross-link it? Well, they felt that using sorbitol would do the trick. And sorbitol is the sugar alcohol that has an antioxidant, that is an antioxidant. And that antioxidant property of itself prevents degradation, just like how you've been taught in all of our basic science lectures. Sorbitol protects against free radicals and degradation, which, if you think about it, very well may help shelf life of product. If you're buying a good amount of product and it's sitting on your shelf for 6 months or 12 months, how's that product holding itself up? Well, we're going to get to a slide that sort of talks about that in a second. But the sorbitol component, it stabilizes the product along the shelf life. It is not a methodology for chemical cross-linking, but is methodology for stabilizing that HA. And in itself, like I mentioned before, the prolotherapy physicians on this video call or on this call might talk to you about how there is this quality of reducing inflammation, creating faster pain relief as a result of these sugar alcohols. So when we think about sorbitol and how it compares under some degree of degradation and oxidative stress, this graph describes a cross-linked HA versus Synolus, which is a non-cross-linked HA, up against H2O2 hydrogen peroxide, and it stood up in terms of its elasticity even better than the cross-linked HAs. There's something about that turgor when you feel Synolus in your hands that is impressive about it. Another briefer medical study was published where some of the products that we know and some that we don't know, I think they're more available in Europe, were compared where the turgor of the HA, which is again sort of its viscoelasticity, how did it stand up to a degree of oxidative stress? And this is a really interesting picture of 3 hours at 60 degrees Celsius, certainly a high degree of stress on a product. And Synolus's product stays very elastic at that time. It avoids degradation. So, in summary, why sorbitol? It's a natural antioxidant, that preserves the HA. It stabilizes the product across its shelf life. It avoids using chemical cross-linkage, which may be a factor in reactions and the safety profile. It very well may give faster pain relief. That's the VA in Synolus VA. And there is the idea of reduction of inflammation via the methodology of antioxidant. And this is just stating the obvious in the 2 mil and 4 mil formulations. Okay. I don't know how many of you have seen this slide before, but certainly something that's been very helpful to us in the musculoskeletal community was studies published regarding statistical and clinical significance for MSK interventions. These studies were published down in Ontario by some very talented doctors who I think we all respect. And that red line there is essentially above that red line says what makes a clinical significance when we, as an intervention for MSK issues, in particular arthritis. Of particular interest is, to people is the HA component. And so when you start hitting HAs that are in the high molecular weight category, that is certainly when patients will experience a clinically significant impact. And I want to decipher statistical significance from clinical significance. That's, statistical significance, certainly it's present, but clinically significant, where it actually has a driving impact for the patient and for our outcomes as clinicians. There's a lot to take in this paper, but I do encourage everyone to read it. But that establishes our baseline that high molecular weight HAs are good, or they are effective. So when you're dealing with an HA that is maybe not high molecular weight, then you certainly have to consider the cross-linking effect. However, is it as effective? It's debatable, of course. And that initial focus was always on molecular weight without discussion of concentration. Greater than 2 megadaltons is considered high molecular weight typically. So we can highlight the different characteristics of the HAs there. Viscoelasticity, again, is affected by the concentration and the molecular weight. So concentrations have to hit about 10 milligrams per milliliter. And too high of a molecular weight of an HA impairs its ability to go from viscous to elastic. And that creates an unnatural crossover frequency. So essentially it becomes too rigid of a joint. It stays in its viscous state at all times. So factors to consider when choosing your HA. So high molecular weight isn't always the best thing depending on the needs of your patients and essentially their demand on their body, what they're doing. So crossover frequency is something we're just going to touch on now. Synolus was designed actually, with this in mind. We'll see that here. So when we get back to, let's say the branding of this product is, it's intelligent design. It's mimicking the healthy synovial fluid. How? Well, I'm going to go back to the properties of the synovial fluid. When sitting, synovial fluid is in a viscous state, which avoids bones rubbing together. And as a reminder, when a patient is under movement, the synovial fluid becomes more elastic for shock absorption reasons. The synovial fluid of arthritis patients has lost that adaptability. That's what I kind of highlighted earlier in this talk. Is in that little gray area. OA patients, it doesn't change as much. So we have to catch them early. Viscoelasticity sort of as an image. Again, it is a feature of the concentration and molecular weight, which lead to a crossover frequency. But what is crossover frequency? Well, we go back to that textbook. This isn't a concept that I invented or that is a marketing gimmick. It is certainly from the textbook on this, on hyaluronic acid. And within that textbook, chapter 20 highlights for us crossover frequency. So I'm going to blow this diagram up. And what you see here is young, old, and osteoarthritic. And the idea is, at what frequency of movement, does the HA change its property to essentially give you that bounce, to go from viscous to more of an elastic shock absorbing HA or synovial fluid? And what happens in the osteoarthritic patient is it doesn't really cross over. It stays in its viscous state at most times. So that's sort of the state of when somebody is sitting. In the young patient, well, I mean, for anyone who has kids and seen them jump up and down and jump off of trampolines into water pools and whatnot, you're always amazed at how those joints essentially respond. And that's not just because of their bones and they can deal with whatever. It's because their joints, their synovial fluid is different. It is certainly more adaptable. As we get a little bit older, it crosses over a little bit later. So viscosity, can you see my cursor, Connor? I'm just wondering.
Yeah, we can see it.
Okay, so I should have been using it earlier. Viscosity versus elasticity, and it crosses over just a little bit later. And the point where it crosses over is known as the crossover frequency. And that frequency, when we sort of boil this down to a much more readable graph, is 0.4 hertz in the young, healthy patient. In the arthritic patient, there is no crossover. In somebody who's older, it crosses over a little bit later. And so when when Synalis was designed, it was designed with that in mind. And that's the whole idea of intelligent design. You have within your arsenal at your office a product that has a significant viscoelastic quality to it, that does not have chemical cross-linkage, that is a biofermentative origin, non-animal origin HA, of high molecular weight and the right concentration. And all those factors together sort of give it this sweet spot, which allows for that crossover frequency to take hold. And this is essentially that same slide from the start where I described that the arthritic patients don't adapt, whereas when we do viscosupplementation, we are essentially trying to maintain that crossover frequency, but change how elastic we can make our synovial fluid. So, intelligent design, and this is essentially a recap. Patented crossover frequency for Synalis, which mimics viscoelasticity of healthy synovial fluid. That is the branding and marketing, but it certainly is based off of true medical science, which I encourage you all to dig into. Our last little bit is, I'm just going to touch on clinical studies, or maybe we'll touch on that in the discussion if some of the questions come up. Synalis VA has published a number of clinical studies over the years, some of which are probably decently well known, but the representatives on who might be inviting you to this call certainly have all of them if you want to learn more. But I'm just going to quickly summarize. Actually, I'll come back to my experience in a second. A few clinical studies to take note of. So the first thing to know here is that when Synalis is used for grade 1 and 2 osteoarthritis, we as I think treating professionals, what we're hoping to do is relieve patients' pain, certainly. And I certainly get a lot of patients who only have partial responses to all HAs. And I almost, I can feel bad at times because I believe that to be a treatment failure. But in reality, I don't think we can always take everyone's pain down all the way, especially if they're a grade 3, borderline and grade 4 OA. That being said, the clinical studies have shown that the WOMAC scores of grade 1 and 2 OA for Synalis, not only do they show sort of a fast pain relief, but at 6 months, it is statistically significant at 6 months. And further to that, it is statistically significant at 12 months. That's the gray line that you're seeing here. This is Synalis's performance on WOMAC scales. When it got to the grade 3 OA, I'll point out that although it is statistically significant, it is not as prominent of a change from the baseline. And when you get to 12 months, it does not meet clinical significance. So, my clinical experience is sort of along the lines of what this graph shows, which is that we can get a 4, 6, sometimes an 8-month response on patients. It can be even longer, but my patients are frequently cycling in the 6 to 9 month range for repeat HA injections. One of the pitfalls of this, of course, is that when you give a patient an injection, they think that they'll say things like, well, it didn't work, even though they had pain relief for 6 months, but at 12 months, they're not feeling it as well. So I think that as medical professionals, we have to educate patients that this is, it's a treatment that needs to be repeated in order to give you some sort of ongoing relief, along with a number of the other methodologies that were on that previous slide of clinical significance. A few other studies have shown fast pain relief with Synalus. It does come down there. They are noticing reductions within the first week. Formulations can be used for 2 ml injections at 3 times, but this at 6 months, 49% reduction in discomfort. But this isn't the one I really want to focus on. The one I'd rather focus on is what doctors always want to see, which is how does it perform against other HAs? And the truth is, when a Synalus versus Synvisc 1 trial was done for non-inferiority, the idea was, can a non-cross-linked biofermentative origin, a more natural HA that doesn't have as high of a molecular weight, does it perform just as well as an HA that has higher degrees of reactivity, is higher molecular weight with more cross-linkage? Does it perform as well? And when doing a study involving 202 patients with grade 2 and 3 knee osteoarthritis, and this is certainly available to you all, there is 6-month follow-up, and in both cases, we saw, or the study showed, pardon me, that there was significant and fast pain relief with a 40% reduction in discomfort, which was that previous slide. Further to that Synalus VA and Synvisc 1 performed the same, and that the molecular weight of the increased molecular weight doesn't necessarily confer a benefit. In fact, the increased molecular weight can be restrictive to the patient, and that's something I'm telling you from clinical experience as well. So non-animal origin HA with sorbitol was equivalent to a animal origin HA that was cross-linked. So the last piece is, actually there's a study, Connor, that you might want to chat about as well, which is related to how gait has improved with the use of certain HAs, in particular Synalus. But we have seen studies that show improved mobility as a result of use of HAs, but in particular Synalus. And this is what I wanted to emphasize. When using an HA that has this sort of nice feel to it, it's not chemically cross-linked, but it is also has a really good viscoelastic quality to it. The improved mobility and improved functionality certainly is something that it's tough for us as physicians to measure, but I have my patients really referring to what was my clinical experience. I'm going to go back to that in a second. If I just pump back here just a little bit, which is that it's become my preferred treatment for GH joint OA of moderate severity, along with the knee OA cases, particularly in athletic populations. So a person that is showing up grade 2, 3 OA, but they really want to move, they want to get around. So I'm talking about, our downhill skiers, our marathon runners, just patients who want to maintain active lifestyle. Hopefully you're catching them early, and I totally understand that we run practices where patients frequently show up with grade 3, 4 OA, and that's really tough. But I will say my experience is that these cases respond particularly well to Synalus. And I've mentioned here my experience is that patients who are concerned about animal products, like I say vegans, for example, very well might be a better treatment for. People wanting a faster onset, a natural solution with a reduced likelihood of reaction. And when I combine with PRP, due to its safety profile, I always choose Synalus. And trust me, ergonomic design, it matters in your hand after a while. So I'll end it there for now, Connor, and we can kind of open this up a little bit to some of your questions.
Yeah, thank you very much, Nathan. So at this point, we'll open it up to discussion. If anybody has any questions, turn on your video, feel free to verbalize it. We're happy to address them that way. Otherwise, just feel free to pop into the chat with any questions that you may have. Nathan, maybe I'll just kick things off. With respect to Synalus, in terms of the 2-volume formulations, how do you make a determination between using the 2 ml or using the 4 ml?
Well, I mean, the obvious is when you're doing 2 ml formulations for small joints. Number one, it doesn't cost as much and you don't waste as much. Further to that, you get a little bit more feedback with the 2 ml formulations when doing a small joint. I think of MTP joints, especially when doing them under ultrasound, you don't want to add too much expansion. You can kind of feel it a little bit better. That being said, I know there are protocols that people do where they do 2 mils 3 times. My protocol for that, for a large joint, 2 mils 3 times. I typically just use the 4 mil for large joints. And I think that everyone has to have a degree of clinical experience where, based off of the size of the individual, more HA may be required or less.
Mm-hmm. Mm-hmm. We have a question here from Anne in the chat. Nathan, is your typical injection series 1 to 3 injections every 6 months? And also, what are your thoughts with HA and PRP injections, 1 to 3 injections every 6 months for NEOA? So HA on its own, and then HA and PRP every 6 months for NEOA.
Yeah, so the thing I want us all to remember is that, medical doctors, we're thinking, oh, we have to treat disease and pain when it's really, really bad. But now what I'm finding is we're getting a lot of patients who are showing up in a proactive format. They do not want to wait to look like their grandparents and have really, really bad joints. And certainly when we talk about health span versus lifespan, patients want to be treated earlier. And Synalus is truly, in my opinion, it is the best product for those early to moderate cases. Now, what do I do in terms of timing? Those patients will essentially be on a 6 or 12-month cycle. If they have grade 2, borderline and grade 3 OA, if they're mildly symptomatic, we inject them every 6, maybe 9 months. If they have lasting relief up to 12, that's great. But I don't go, once I start a patient on HA, as long as they are maintaining a good lifestyle and their joint is not, deteriorating rapidly, we will certainly inject them once a year at the latest, but preferably 6 to 12 months. The second question there about PRP, Connor, can you classify that question for me again?
Yeah, just to repeat it, with HA and PRP injections, 1 to 3 injections every 6 months for NEOA. And I'm not sure if you're referring to combination therapy or independent of one another. There is another question just below by Dr. Ammon looking at combining PRP and HA. So Nathan, maybe touch on just whether you follow the same PRP protocol in terms of number of injections and timeline as you would with HA, and then following that up with just a brief note on combination therapy.
Sure. Okay. I'll try to cover this in as much detail as I can. So PRP and HA. So the first thing I'll state is don't combine it in a syringe. Bad idea. There is a good chance that you'll actually activate the PRP itself within the HA. And, you can think of it as getting trapped and not having the full effect within the joint. When combining, we will inject the PRP first, followed by the HA on the first day of treatment. Our PRP protocol is for 3 treatments at 1 to 2 week intervals. Some people stretch them up to a month, but data suggests that 1 to 2 week intervals are better. And a study in 2016 done by Lana from Brazil and Steve Sampson from California, Steve Sampson being one of the best leaders in regenerative biologics out there. Their study suggested that using 2 mLs combined with PRP, not in the same syringe, but injected simultaneously, led to faster onset of action. And that's why I actually just take the approach of, I just put 4 mils of Synalus into the joint on the first day after their first PRP injection. And therefore, patients will begin to perceive an improvement early on while the PRP is kicking in over the 2 to 3 month time period. Connor, does that answer that question thoroughly enough?
Yeah, Anne and Dr. Ammon, if you want to just chime in, if there's any follow-up question to that, or if we covered it, that would be perfect. We got another question here. Do you mix your hyaluronic acid, presumably, with cortisone at all?
Yes, in cases where there is an acute flare or the pain is intractable, we will mix our cortisone and HA. But I will tell you this. At the point where a patient is having significant pain and you're hoping that the HA is going to make an added difference, and that pain is sort of, they're a grade 3.5 away, if you could call it grade 3.5. The HA almost never adds a significant benefit. The amount that, if you were to inject them with cortisone alone versus cortisone with HA, they don't get any significantly increased pain relief, and certainly they don't get it for longer. I think we all hope that it would be longer, but it's not always the case. So I combine if there's an acute flare, but the idea of using Cingal, for example, which I have in my office, but I rarely use it because I don't understand. First of all, I don't understand why anyone wants to cramp their hand that much trying to push that stuff through. But on top of that, you can combine it on your own and you can tailor the dosage of your cortisone if need be. And it seems to be a smarter approach because we do have medical studies that suggest that 20 milligrams of cortisone or Kenalog is as effective as 40, and maybe not quite as effective, but in the milder cases. So we're only using that combination in acute flares or when people are too far gone and maybe they're no longer a great orthobiologics candidate.
Mm-hmm. In follow-up to that, another question, which PRP system do you use when you're mixing it with HA? And then any role in inflammatory arthritis? Shama, let me know if I captured that question correctly.
So I use a few different systems. So first of all, Connor can educate you on the system that MD Biologics uses, which is the Servos Key PRP system. So that's probably a good one for you to look into. We also use Arthrex Angel in our practice, in particular for tendinopathies, because we create PRP gels as well as we move into PRP 2.0. So it can be a mixed bag of what we use, but PRP, I'll tell you, is a science in itself. The aesthetics community has done a really good job of making it something too simplistic. And as the sports medicine community learns about it, I think we have to expect more of ourselves and learn the details. It's not just about the system itself. It's about tailoring the PRP to the patient problem. And, the truth is I can go into a 2-hour lecture on that. We have a PRP-HA combination lecture, but certainly PRP in itself, different systems for different use case scenarios.
Yeah, if anyone's interested in attending a future webinar where we discuss specifically combination therapy, PRP and HA, feel free to chime into the chat. We'll make sure that we get you registered for that. Nathan, I don't see any more questions. We do have a few more minutes here. One that I get. Oh, Dr. Carmi, do you have one?
Hello.
Hey, Gregory. How are you?
Long time no see.
Yeah, well, I'll see you again soon, I'm sure.
Hopefully. Quick question. I think in the back of my mind, I remember somebody promoting hyaluronic acid for tendons. Am I wrong, or was there something about that?
Yeah, there is something about that. Gregory, you must be familiar with SportVis now.
Maybe.
No? Okay. Yeah. There's a product out there that is a hyaluronic acid for tendinopathy. Actually, I shouldn't say it's for tendinopathy. The indication is for lateral epicondyle and also for the ATFL. My experience is like I almost never use it. It's not nobody has ever come back to me and said, "Oh wow, thank you for giving me SportVis, doctor. You really helped me." Not a single patient. So I've stayed away from it. That being said, in the United States, Gregory, there are a couple people that are combining PRP and HA, and they use the HA as a scaffolding inside of tendons. Again, it is not a well-founded methodology. It is simply something that people are doing with the idea that the HA may have some building block characteristics for tendons, but very debatable. But look into SportVis. Look into SportVis if you're interested in that.
No, I just want stuff that works.
Yeah, of course you do.
Fantastic. I was just about to follow up. One question that we get asked often is obviously now with this sort of new idea of viscoelasticity and recognizing that certain products fit into different areas of that spectrum, with products that are very high molecular weight or have sort of asymmetrical viscosity versus elasticity, where do you plug those into your practice? As an example, products that do have a very, very high molecular weight, where do you fit those into your practice?
Sure. If a product has a very high molecular weight, so remember, we're thinking there's a closed system, which is the joint, and the high molecular weight is going to sit in a more viscous state. So it's creating a more rigid system. And those would be used possibly in older patients with reduced mobility or in greater severities of osteoarthritis. That's when I would use it. And I also say when, like a great use, for example, for Synvisc 1 is in patellofemoral syndrome, where you really need more lift off of the patella off of the femur. So you're introducing a greater volume in a more viscous state, which may help it a little bit more. But really, Connor, that's a clinical experience thing, or I'd say that's a clinical practice that I use. I don't think that we have evidence of that, but what we do have is this wonderful textbook that suggests that with patients who have high demands of mobility, you want to use a more viscoelastic substance. And that's why I encourage everybody, like, Synalus should be a part of your practice either way, especially for the athletic populations. You will serve them very well. Younger, in that 40 to 65-year-old age category, you'll do very well with this product and patients are very happy. The heavier products, again, via experience, the grade 3 to 4 OA or reduced mobility patients, that's when you might want to use them.
Mm-hmm.
You need to essentially create more space in a joint.
Yeah, perfect. Any last questions here from anybody?
I don't know. Is my mic working?
Yes, it is.
Yeah,
okay, cool.
sounds like Garrett.
Hey, Garrett, how are you?
Good. How are you doing? I had the curiosity question comparing, Durolane or Monovisc or Synalus. Do you see any difference in flare-up potential? Like the odd person, 5% of people flare up to Durolane in my experience. Do you have those same impacts with Synalus, or is it improved safety profile that way, especially when you're combining with PRP?
If you're getting a 5% flare rate, do you say with Durolane?
From what I've seen, it's typically with patients who have a lot more joint dysfunction.
Sure. Okay. So 5% would be quite high, and certainly, definitely not your fault, but it is just like a fact of clinical life and practice. The published rates on Durolane are quite good in terms of its safety profile. That being said, Synalus is even better in terms of its reaction rates. It is a more modern biofermentative process that's being used now, and it doesn't have the cross-linking. So, as a reminder to everyone who doesn't know, chemical cross-linking is typically done by formaldehyde, which is a irritant in most cases. And that's why we try to avoid it with that's why you might avoid it with a more natural substance. My safety profile on Synalus has been exceptional. The only time I've had a reaction is when I actually put too much HA into the joint. And the classic example will be an MTP joint putting in the full 2 milliliters into an arthritic MTP joint. But the reaction that they're having there is a flare from you actually prying that thing apart. And it gets perceived as an acute reaction, but it's not. It's actually just, too much in a space. But other than that, I don't think you should have flares from it, because the flare rate, I think it was at 1 in 10,000.
Yeah, I think it's more the space thing. I had one person flare to it, and I think it was more so just placement, but more so just pressure or space increasing.
In fact, Garrett, I'd say that if you've had a patient that's had a reaction to HA and let's say the patient still wants to try or do something, what you typically might end up doing is, HA chased with cortisone, or as part of our protocol, anyone who has a mild reaction will just Benadryl them on the same day. But I would suggest to you that patients who have had previous reactions use Synalus on those patients because of the safety profile and its exceedingly low reactivity, no chemical cross-linkage.
I followed a similar protocol to what you expressed. Good.
Very good.
That's limited in most people, but I was just curious on what your experience was.
Stuff that you and I have had to figure out from experience, right? Like when they call you back to the office, you're like, oh, damn.
Never a great day. No, that makes a lot of sense. And I've seen Synalus work really well in athletes as well, and I've played around with it a little bit, but looked at it more so once we burn through the rest of the stuff.
Good stuff. Thank you for chiming in. There's a lot
we
of
do have one last
there.
question here from Anita. What do you use for tendons if you don't like SportVis?
PRP. PRP is my tendon treatment of choice. Tendon treatment is, Anita, I don't know your background at all, but under ultrasound guidance, tendon treatment is a very nuanced treatment. If there's tearing, is there a roof to that tear? Is it an open mouth tear? Does it have a communication with a bursa? But if you are able to figure all that out, PRP, as long as it is contained within that tendon for tendinosis versus the different kinds of tearing, I would choose it every day of the week over SportVis. The only time SportVis has ever been effective for me is when I did PRP to a lateral epicondyle, and they had a 90% resolution, but they're like, I still feel just a little bit left over. I say to the patient, I don't want you to go through all that pain again with an intra-substance PRP injection. Therefore, I'll just try the SportVis to get rid of that last 10 to 15%. And sometimes it works and sometimes it doesn't still. So
I missed the beginning. It's Anita here. And I don't know if you're from Canada, but most people can't afford PRP. And the first reason I give them HA first is that most insurance companies cover it. So that's why I offer the HA first, even for tendons.
good.
And then if they go for PRP, that's great. I say that's usually a better option, but it's really hard to get people to buy in when they're not covered.
Certainly. I think we all face that problem. My practices are probably a little bit different, that people get specifically referred for last resort therapy almost. But primary care setting for sports medicine, it can be tough. I empathize with you. That being said, my success rates with HA have been mediocre at best. So maybe you're doing it better than I am or something of that nature. So hopefully it works for you.
Okay, and we have one more question here. Any role of hyaluronic acid as prevention in gout, psoriasis, or any inflammatory condition?
Okay. I don't have an answer for gout or psoriasis. I really don't. Very specific clinical scenarios. I will say, though, that In 2018, an excellent research study done in Hong Kong measured biomarkers for inflammation in the blood and the joints in patients who were injected with PRP, HA alone, and PRP combined with HA. And the results, which they did such a good job with, like when you read this study, you're going to be so impressed with like the thoughtfulness of how they approached it, the injection, the timing of the blood draws, the timing of the synovial fluid samples. But the answer was that all three led to reduced levels of inflammatory markers in the blood, but far more significantly, there was reduced levels of inflammatory markers in the joints. And that was for HA, PRP, and HA plus PRP combined. The HA plus PRP group combined outperformed both of them. HA does have an anti-inflammatory effect within the joint. Is it going to solve a psoriasis, or sorry, a psoriatic arthritis or a gout or rheumatism problem? No. But I don't know that we have a whole lot of information on that at this point. Somebody tell me otherwise. But that article, which, you know, if you ask Connor for it, I'm sure he'll give it to you. And if he doesn't have it, I have it.
Awesome. Okay, well, we're about 7 minutes over, so why don't we wrap up here? Nathan, you and I can maybe stick around if anyone wants to hang out for a few more minutes. I know Garrett might have a question here about the PRP gel process that you mentioned, but we'll hang around for a few more minutes. Just want to thank you again, Nathan, for taking the time to share your clinical insights with everybody. This recording will be made available for everybody that's on the call, so if you missed anything, if you joined late or you left early, we'll be sure to circulate that. And always looking forward to seeing you all on future webinars, and please keep in touch. Have a good evening.
Yes, thank you. Hopefully it was helpful. Nope, everyone's gone.